Welcome to the ALAI UP Project Pre-Application Assistance webinar. I think in the interest of time, I'm going to get going right now and we'll keep admitting people as they join. My name is Katrine Myers and I will be leading today's webinar. By way of introduction, I've spent about 20 years working in the field of HIV, first globally and more recently closer to home in the US. And the work that I find most rewarding is supporting clinics and integrating new HIV-related services into clinic flows. And I've done that in a variety of sort of spaces and ways. And it started with, in the early 2000s, integrating routine HIV screening into prenatal care. And when that was not routinely done. I've also worked on projects to help create linkages between ID clinics and antenatal care that facilitate immediate initiation of ARVs for all pregnant women, and then prophylactic dosing for their neonates. And more recently, my work has been focused on introducing oral and long-acting PrEP into a diversity of clinics, sexual health clinics, FQHCs, community health centers. So I wanted to start with that because partnering with clinics to help identify what they need to introduce new services and then designing technical assistance and training to support them is what the ALAI UP Project is really all about. I am joined in this effort by a truly amazing team of clinicians, pharmacists, trainers, and technical assistance providers, some of whom are here on the call today. And I think all of us have written ALAI UP in our names, so you can see them. Some of these folks are here with me in New York at Columbia University, at the New York City Department of Health, and at Hunter College. And then we also have collaborators in Tennessee at the Southeast AIDS Education and Training Center. So today's webinar will be in two parts. I'll first take you through the RFA, and then we'll have a Q&A session. Please feel free to use the chat to ask questions throughout. Some of my colleagues are going to be monitoring the chat. Nadia may reply to your chat if it's an easy answer, and then others will be brought for the group at the end of the session during our Q&A. We are recording this webinar so that those who couldn't join us today will be able to view it. And the recording and the slides will be available on our website on Monday. All right, so as you know, if you've seen the RFA, the full name of the ALAI UP Project is Accelerating Implementation of Multilevel Strategies to Advance Long Acting Injectables for Underserved Populations. And that is really, in a nutshell, the mission of this HRSA-funded project. So our goal in this project is to increase access to uptake of long-acting injectable ARVs in areas that are most impacted by the HIV epidemic by identifying and partnering with clinical sites working in these geographic areas and with these populations. We believe that by expanding access to long-acting injectables at these sites, we'll be able to work towards reducing HIV-related health inequities in achieving and maintaining viral suppression. So how will we do this? We'll do this by selecting clinical sites that work in communities most impacted by HIV, that serve communities of color and populations who have been historically excluded and underserved, and that we're looking for sites that will be active partners in the co-creation of protocols that can help other sites accelerate their implementation of long-acting ARVs in the future through what we learn together. We understand that given the current clinical eligibility criteria to initiate individuals on injectable CAB and rilpivirine, there is, of course, a limit to how impactful this particular regimen can be on decreasing disparities at a population level. So this project we also see as really only the first step. It's our hope that what we can learn with our clinical partners in this project will allow us to be ready if and when the eligibility criteria becomes more inclusive for this regimen, and help us prepare for implementation of future injectable regimens as they become approved, so that future injectable regimens can be implemented quickly and, very important to us, equitably across all different kinds of clinics. In the RFA, we specified sort of the commitments in sections 3 and 4 that the ALAI UP team will make to clinical sites, and then the commitments that sites are asked to make to the ALAI UP project if they're interested in becoming partners. These are listed in the slides that follow as project activities, and then I'm going to take you through these so that applicants can have additional clarity on what they would be receiving and co-creating with us, and what they would be asked to provide in return. I'm going to take some time to go through this so that when you're thinking about budgeting time and effort of your personnel, and resources and other costs, you'll be able to reference these slides to inform your budgeting. So here, these are the 9 different types of project activities, and in the slides that follow, I'm going to go through each of them. To orient you to this sort of table here, on the left-hand column in blue is the name of the activity type. In this case, it's community engagement. In the ALAI UP team column, we elaborate on what the central ALAI UP team will provide. And then in the column on the right is what we are hoping that what clinical sites will be able to commit as part of the project. So first, we describe what we mean by the activity. And I'm taking my time through this because all the slides that follow have the same format. So first, we have a description. We describe what we mean by this activity. In this case, for community engagement, we envision community listening sessions as the strategy by which sites elicit feedback from their patient community, as well as people who may actually be struggling to access care, because these are, of course, equally important if we can find ways to identify them and engage them, so that we can really understand the needs and wants of people with HIV for the care that they access. The ALAI UP team has a community engagement lead who will provide support to sites in the planning and conduct of these listening sessions. And so this now on the slide, you see the activity and some description of what ALAI UP team will provide. On the right-hand side, we then describe the activities that we would expect the site to conduct and include a deliverable of what we would expect from the activity. So here, for example, we would ask that after a listening session is held, the site provides a written summary of the event, key takeaways, and initial thoughts about what that site will do to address barriers elicited through this process. We, of course, understand that not all barriers are immediately solvable, but we are eager to start with this community engagement and listening session to drive home the fact that we recognize, the project wants to recognize the expertise of patients with lived experience accessing and not accessing care, that we want to listen to them and think creatively about how the ALAI UP team and the funding provided to sites can be deployed to tackle whatever issue has been raised by the community of patients. So I'll go through the next slides a little bit faster now that you're oriented to how they are organized. So here we have activity 2. This is a needs assessment that's done through detailing. I'm sure most of you are familiar with pharmaceutical detailing. Public health detailing has been adopted by the New York City Department of Health, and I'm sure others, as a way to understand the needs, the strengths, and the challenges that sites face when introducing a new intervention. The ALAI UP team will assign a detailer to each site, and then that detailer will really be your point of contact to work quickly to set up meetings with key personnel at your site to have short 15 to 30-minute virtual detailing meetings that will allow us to really get a quick understanding of what's sort of the reality on the ground at your site. We anticipate, and there'll be some flexibility as we work through this process together. We anticipate that most sites will have 4 to 6 detailing sessions in the first few months of the project, and that different sites may organize it differently. We have found that detailing done with individuals at the site is an effective way to do it. So on week 1, we might talk to a nurse, and on day, in week 2, we might talk to a navigator. So we want to make sure that different staff at the sites feel able to make their opinions and voices heard as well in these sessions. I encourage you to read what we've laid out in each of these slides when you're preparing your own application, as there's more detail on each of the sort of the activity and then the deliverables for each of these project activities. The third activity is really at the heart of what we're trying to do in the ALAI UP project. It is the co-development of a set of tools that clinics will use to get their injectable treatment program off the ground or scaled up and sustained over time. The ALAI UP team is developing a draft set of these tools right now. We're synthesizing documents that are already available in the public domain, and we're conducting interviews with clinics that already have sort of 75 plus patients on Cabenuva, and trying to digest all of that and create these draft tools. Likely in June of 2023, ALAI UP will hold our first annual meeting, where we hope that 2 to 3 representatives from clinical sites will gather, ideally in person, to review the beta version of these tools and resources and think about how to apply them to their own sites. A few months later, we will gather again. So in the first year of the project, we would have 2 in-person meetings, ideally in person. Clinical sites will share any written protocols that they've developed, how they're working or not working. And then if protocols have not yet been written, which we find often happens, we want to take time during that second meeting to give clinicians or the champions that come time to actually sit down and write. So we'll have designated writing sessions if necessary to give people time to sit down and write these things out. Through these implementation workshops, we plan that all sites would have written protocols for all aspects of their program by October or November in 2023. If you are a site that already has an injectable treatment program and is really interested in scaling up, then the protocols would be about that scale up. The next project activity is technical assistance. So as all of you know, writing down the protocol is a huge first step and critical for building a systematic approach to services that doesn't rely on one individual who might go on maternity leave or take another job at any moment. But writing down the protocol is not enough. We find that sites often reflect that they need technical assistance on how to implement that protocol. So each site will be assigned an implementation coach who will deliver tailored technical assistance through a series of monthly calls with the clinical sites. These calls are intended to serve the site by being responsive to whatever issue that site is experiencing. The central ALAI UP team will include members with expertise in each specific component of the delivery of injectable treatment. And so each site's implementation coach can call in and bring in expertise in specific areas as needed. Sites will be expected to participate in these TA calls monthly in year 1 and then moving to bi-monthly if appropriate in year 2. Activity 5, communities of practice. We strongly believe that one of the most important things that the ALAI UP project will be able to do is facilitate site-to-site learning. Often the most effective way to problem solve is by sites sharing their experiences with each other. We're therefore going to devote time at each of the annual meetings for community of practice sessions where clinical sites have the opportunity to share with each other. And then in addition, we'll hold virtual communities of practice every other month. And those will replace some of the monthly TA calls. When sites tell us that the utility of the communities of practice outweigh the utility of the TA calls. So this is where we are building in some flexibility in the project so that it really is responsive to what the clinical partner sites tell us they want and need. Continuous quality improvement. ALAI UP is committed to using a CQI approach We want to work with clinical sites to look at their data and understand what's working in their protocols and what could be working better, particularly in relation to equity. So it's really critical that clinical partners have a way to collect data and to report data. As much as possible, we are going to limit ourselves to asking for data that you already report to Ryan White programs or local health departments. We want to minimize additional data burden, but increase the utility of the data to you. We will ask for quarterly data reports that include your routine HIV-related patient outcomes for your total population of patients with HIV, and then disaggregated by key equity dimensions like race, ethnicity, age, gender, poverty, insurance status, as well as by regimen. So we will be asking for data on your whole population of patients with HIV, and then disaggregated by oral versus injectable regimens, so we can understand a little bit about how equitably injectable regimen is being introduced. All right. The next activity is monitoring the process of implementation. So here is where clinical sites will really become partners in generating knowledge about what it takes to implement injectable treatment, so that later we can help teach other sites how to do this. The ALAI UP team will be documenting the process to see where across our 8, to see whether across our 8 clinical sites, we can identify exactly what is needed to get injectable treatment into settings efficiently and equitably. We'll do this by taking notes on how it's going at your site, and also through periodic phone calls to check in with your site's implementation champion in order to ensure that we're understanding what's happening, when, by whom, so that, again, we can synthesize what we're learning and build tools and resources that can support other sites. The next activity is closely related to the previous one. We want to understand 2 and only 2 components of costs associated with introducing injectable treatment. We want to understand how much time it takes to do all the things that you're doing to deliver injectable treatment and whose time it takes. And then we want to know if you had to spend money on anything. Did you buy a new fridge? Did you have to pay to make changes to your EMR? So I want to be clear that this is not at the level of granularity of like a time motion study. Instead, it's those periodic phone calls would be with the implementation champion, and we would be asking that person to give us sort of a best guess estimate of how much time and money is spent in each of these activities that are being carried out in the process of implementation. And then finally, we're very committed to evaluating ourselves and evaluating the extent to which clinical sites are satisfied and find ALAI UP activities useful or not useful. We want to do this so that we can learn what is actually helpful, what needs to be changed or improved, and what is just deemed unnecessary. And so we'll be asking clinical partner sites to evaluate our activities through short satisfaction surveys after trainings or TA encounters. And once a year, we'll ask sites to participate in a focus group or a meeting where we'll actually bring in a third-party evaluator so that you would feel free to be very honest about what's working and what's not working, all in the service of improving and making sure that what we're doing is as helpful to you as possible. All right, so hopefully this has given you more details about what the ALAI UP project plans to do in partnership with selected sites. Now I'm going to just go through the nuts and bolts of the application. This is all spelled out in the RFA, but we'll go through it again now together. The ALAI UP project is funded through a, whoops, sorry about that. The ALAI UP project is funded through a collaborative agreement from HRSA to Columbia University. The project will select 8 sites from anywhere in the US to participate for a 3-year period. Each site will be able to apply for up to $90,000 per year for 3 years for a total of $270,000. Clinics in any US state or territory are welcome to apply. Our minimum eligibility criteria is that a clinical site is providing care to at least 25 people with HIV. The application due date is January 20th. We plan to invite finalists for an interview the week of February 6th, and then move quickly to notify sites of their acceptance by February 17th in the hope of starting our collaboration about 2 weeks later for early March. I will be the first to admit this is a very ambitious timeline, but we think we have all the pieces in place to make this happen. Here you'll see it says step 2. That's because step 1 is registering and showing up for this webinar. So thank you for doing that. Step 2 is requesting access to the online application platform by emailing Ben Lane. Some of you have already done that, so you should have received the link. Let us know if you haven't. And then there is the application itself. So we encourage you to download and compile the following application components. So the clinical questionnaire, you must submit this in REDCap. So we'll send you a link, and then you'll be able to access these questions and enter your answers there. We do recommend that you use the Word version of the document to draft your answers and then copy them into the online application platform, just in case there's anything glitchy with REDCap. There are several attachments. Attachment 1 is a budget spreadsheet. Please use the Excel budget template that we provide to develop a year 1 budget. We're only requesting a year 1 budget at this time because year 1 is the most concrete in terms of what is happening. Years 2 and 3 budget will be requested upon site selection, and we'll do that, collaboratively as we understand more about what your site is doing and needing. Attachment 2 is a budget justification. Please use the template to describe how the requested funds will be used. That's a narrative form. Attachment 3 is a patient demographic table. Please complete it and then send it back to us. And then attachment 4 is optional. Please provide examples of existing protocols and workflows for HIV treatment at your clinic if you have these. Again, this is optional and just to give us a sense of where you're at in terms of protocol development and writing down what it is you do every day in your clinics. We recognize that some of you here today have a lot of experience applying to this type of opportunity, and for others it may be the first time. We've tried as best we could to make this application process straightforward and not to require too much of your time, as we know and deeply appreciate that you're busy taking care of your patients. So I really want to encourage you to reach out if you have any questions. We are here to help. So all the questions will be sort of funneled through Ben Lane, and then we'll distribute them to the people who can answer. So again, these are the remaining dates that I just reviewed. All right, a word on budgeting. The reason, again, that I provided all this detailed information is that we want to make sure that you're budgeting appropriately for staff time and effort and resources to fully participate in the project. So what funding can be used for is shown on the left. It's a very short category, and in the other category, we encourage you to use that as needed. So personnel, supplies, equipment, meeting, convening, travel, and then other. We expect that you will have other categories, and please use that category as needed. Not allowable is providing general health care, medication purchase, shipping or storing medications through a third party, purchasing or construction of property, international travel, and payment of items or services covered through health benefits or insurance programs. These are passed down to us by HRSA. So again, we're here to help. During the Q&A session, we have Jay Lawful here from our team here at Columbia, who can also help answer any questions. So again, there's a budget spreadsheet, a justification, and a first-year budget. All right, so next I'm going to take a little bit of time to go through the 7 criteria that we will consider in making our site selection, and the relative weight that we will give each of these dimensions or criteria when reviewing applications. So first will be the history of community engagement and outreach, specifically to underserved populations. So this will make up about 15%, or not about that, this will make up 15% of the site's overall score. And the things we're looking for here is a history of addressing social and structural barriers to care, the provision of wraparound services to support other health needs, and a demonstrated commitment to achieving equity in patient access to injectable ARVs at your clinic. Criteria 2, having an experienced and motivated project champion and implementation team. This will also make up 15% of the score. So what are some of the things that we would evaluate when considering this criteria? Whether you have an experienced project champion or have identified someone who could serve as such, and importantly, a convincing plan of how this person will gather and sustain buy-in at all levels of the institution and the clinic. We also want to ensure that you have a diverse implementation team who are willing and able to support activities not only in the first year, but also in the second and third year. And then again, if you don't have such a team in place, a plan for how you would identify this person or modify clinic roles to generate that. The third dimension, which is given a weight of 10% in our scoring system, is the size of your HIV program and organizational readiness to introduce or scale up injectable treatment. Here we are interested in knowing the number of people with HIV whom you serve and what your goals are for switching people, sort of what proportion of your patient population would you imagine switching to injectable regimen, and the extent to which you are ready, are already implementing or ready to begin planning for implementation of injectable regimens. 15% of the score will be devoted to data infrastructure. Here we're looking to see to what extent you have a system in place that can support collecting and reporting aggregate patient level data. So we're not looking for patient line data. We're looking for aggregate data, but disaggregated by key equity dimensions. So again, to the extent possible, we won't be asking for many additional items beyond what you're already reporting. If you look at the attachment with the demographics, patient demographics that we're asking for, this is the kind of data that we anticipate we would be asking for, and so that gives you a sense of the patient outcomes data. There'll also be sort of data related to a process of how you are implementing. If you have 10 providers, we might be interested in understanding disaggregation by provider as well. But we would get into more of those details with our clinical partner sites and involve partners in the process of developing these metrics. As described earlier, we're committed to using a CQI approach in this project. And so this is a weight of 5%. We would like to know whether your clinic has experience using data to evaluate whether a new initiative is working as intended, and or what you do when you see that it isn't working as expected. So we're looking for examples of changes that your clinic might have made in the context of a quality improvement project. Yeah. All right, here, this is, again, 15% of the total score. Motivation and ability and follow through. We want to partner with sites who are motivated to be full partners in this project. We all, I'm sure, have experienced projects where initial motivation and engagement is very high, but wanes over the years of the project. So we are interested in sort of learning from you how you can maintain your commitment meaningfully over the 3-year period, and how you would intend to ensure that you are able to set aside the necessary staff time and resources to fully participate in ALAI UP. And then finally, we are putting a lot of weight on this last criteria, which we call generalizability and diversity. As I hope I've explained, we are really committed to helping you in your implementation process, first and foremost. But at the same time, another project goal is to make sure that what we create and learn in ALAI UP together can help us accelerate implementation of injectable treatment more broadly. So that is why we're going to be looking for a diverse cohort where each clinic is able to contribute something unique, unique information or perspective that could be generalizable to other sites of its kind. So in other words, we're looking to understand why your particular site could be an exemplar or sort of a good example of for other clinics of a similar type, and how helping your clinic would help other clinics like yours in the future. All right, so that was a lot of me talking, and I'm now going to hand it over to Brian Kuttner, who is my colleague who has been monitoring the chat, and he is going to help us facilitate the Q&A.